the network for health, for broader health, multidisciplinary network for tuberculosis, TB, and standard opera, this Mexican CDC, as well as the National Research Network for the Control and Diagnosis of TB in Mexico. This virtual international forum on TB 2022 has a purpose to generate an open channel of communication and exchange of scientific information internationally and domestically regarding the prevention, diagnosis, and treatment of TB in order to meet the end of tuberculosis goal established by the WHO. This strategy wants to reduce 90% of the disease for people from TB by 2030. Regarding the baseline values for 2015, TB is one of the most lethal infectious diseases worldwide. It's important to remember that every day more than 4,000, more thousand people die a day from TB around the world. TB can be cured if it's detected on time and if the treatment is completed. Also remind you, those who are here with us, that we're gonna issue diplomas, attendance diplomas, if you follow the requirements set forth in the www.remitv.org website. So you can check that website for details. Also, for those who haven't logged in on the same page, you're gonna find the link to the record form, and also you can use the QR code on the screen during the session. You only have to be logged in once. Now, I will introduce Dr. Luis Alejandro Rubido Espinosa, who is responsible for the TB program and respiratory and influenza diseases in Ensenada by the Ministry of Health of the state of Baja California. Mr. Pulido, who will be moderating today's session. Thank you, Doctor. Hi, good morning, everyone. It's a pleasure for me to be here. Thank you for the invitation. And yes, a true honor to be able to introduce the different Dr. Rafael Laniado Laborín as the first speaker. Dr. Laniado Laborín he graduated as a surgeon by the University of Baja, specialized in pneumology in Sonora. He has a master's in by the San Diego State University. He is a pneumologist at the General Hospital of Tijuana. He also works at the Medicine Psychology School in Baja California since 1987. He's currently the chief of TB clinic and lab at the General Hospital of Tijuana. He's also worked on the guideline, the preparedness of the guidelines for TB in years 2017, 18, 19, and 22. Currently, he's member of the Green Light Committee of the Americas by WHO in order to control drug-resistant TB in Latin America and the Caribbean. He's also a member of the National Research Team since year 2007. Thank you, Dr. Lamiado, for being here. Now, you're talking about comprehensive management of drug-resistant TB. Yes, first of all, I would like to thank the National Mexican Network for Researchers of Tuberculosis for the invitation. I'm gonna turn off my camera so the internet does not act up. So I chose this subject that you might be wondering what it's all about. First of all, I don't have any interest in conflicts of interest. And one of the problems that we have with TB, drug-resistant TB, is the results. What are the results from obtained through the treatment for TB? The results may vary from one region to another, but we might see that in MDR-TB that the rate of treatment of success rate is about a little above 52%. About half the patients are cured, and the rest may just lose track of their treatment. If the treatment fails or they die. So we cannot be very proud of this outcomes. So why is this happening? Why are we doing so bad around the world? particularly in the Americas. And the reason is that maybe our program is not patient focused. So the comprehensive management includes all that you can see on the screen. We need to be we need solid ethics, and we need to protect human rights, access to diagnosis and treatment, proper treatment and diagnosis, counseling for the patient and assessments of their needs, psychological support, material support, social protection. We might be wondering if does my program offer all this? You should be wondering if you're asking yourself if your TB resistant programs, if your drug resistant TB programs contain all these elements. So the WHO policy for managing MDR TB includes these 5 points: diagnosis with new techniques, currently, molecularly the molecular type, treatment with new drugs and reused drugs, also the active pharmacovigilance surveillance. So now we need to find actively see if there are any side effects on the drugs or not. The attention we should be focusing on patient and lastly, infection control. What does patient-centered attention for someone with MDR TB? So it involves several things. First of all, we need to have the DOT, community DOT. I will tell you what that's all about. Also, you need to train our staff, material support, household visits, psychology support, financial incentives, counseling for the patient. Currently, most of the countries in our region, the treatment for TB is focused on the system. It focuses only on the system. So we do what's best for us as part of the system. So, for example, if we tell the patient, okay, your treatment must be surveilled. So you need to be supervised. So you need to come to our clinic so I can administer the drug to you. That's very convenient for us because the patient has to come to us. But when you focus the attention on the patient means that we have to take the medication to them. So unfortunately, this kind of it brings about the lack of follow-up for on the treatment. We lose patients. So this was the pillars for this treatment, and the WHO includes integrated prevention and attention on TB focused on patients. This is nothing new. WHO has been talking about this for 7 and 8 years, so we are not paying attention, but it's there. And also, we need to implement very smart policies and supporting systems. We may think, no, we have always done things this way, but no, it says, but you have always done it wrong, so you cannot expect good results. The end result expected is to promote and protect human rights, act with ethics and equity towards patients. TB, and these are the standards for tuberculosis treatment. Well, basically, what the WHO standards promote adherence to improve and to make sure the patient completes the treatment, improve quality of life, and relieve suffering. Those are the basic principles that we must follow and observe. So, what are the WHO recommendations for this? So we can provide a patient-focused approach. We need to pay attention to comorbidities, whatever they are. But the most common in our region are diabetes and HIV. Basically, half of all the patients that we see with MDR TB are diabetic, and all of them are not under control. So they give metformin for all the patients, and they cannot control anything. So also we need to address diabetes and as well as HIV. So if we don't pay attention to comorbidities, then patients will not get better. A serious problem for our country is that we always complain that we live next to a racist neighbor, but we are racist ourselves, and there is a big stigma for TB, people living with TB. People with TB are mistreated, and even the people at clinics and healthcare workers This is a publication by some of the guys that working at the clinic where they investigated why patients would go back to the emergency services. That was like that they're the treating doctor for TB, which should not be the case. And then what they realized is 40% of the patients who were readmitted did not go to the referral health unit, and they wouldn't go there for several reasons. The time was not the right time. It was maybe in the morning. The number of appointments was limited, and also the way they were treated. They were they were disrespectfully treated there, especially when they had TB. So this is going. I'm trying to drive, but this is going so slow. This presentation is not moving forward. Froze. So in order to support the patient and treat the patient, the individual recommendation is to have transversal interventions for MDR TB. This includes you need to educate patients, and we have an intervention package in order to improve adherence. When we say that this should be transversal, we are trying to say is that, for instance, in Mexico, we have several programs that they work isolated. They have very little communication among them. So it's not uncommon to see in the American region to see when we go visit different countries that, for instance, the HIV and TB programs are divorced. They are not together. They're not linked, and they should be working together, elbow to elbow. And there are also some departments that address food security, and they are not part of the TB program. And that's what the WHO talks, and we should have transversal interventions. So what about patient education? A patient, we don't have to tell them what, we don't have to talk about the DNA or the microbacteria. They don't have to know all the technicalities. What they have to know is why they have to adhere to the treatment. What is it that they have to do for the treatment? What should they avoid? And we need to educate on community transmission to protect their family, those kind of things. So patients who are educated or counseling, first of all, compare against those who didn't. They show better successful rates for the treatment. They show better and completion rates for the treatment, better cure rate and adherence rates, and also they have lower rates of loss of treatment. So there is evidence that patient education has an impact on the outcome. So on this publication, we can see how the results, the positive outcomes we see go towards those patients who were educated against the control group. So in some countries, this is from Peru, they give out some flyers, educational flyers with simple information. They tell people with living TB what tuberculosis is, how it can be spread. In Tijuana, here we have others that are not as pretty, but they also work. So we give them patient, they should know. Adherence, we need to have an intervention package to improve adherence because we complain that the patient abandoned treatment, and the WHO said, let's stop using that term, abandoning the term. We're just blaming it on the patient. And the preferred term is the lack of the loss of follow-up. So what we're trying to do is we try to make sure people adhere to the treatment. So then we might have some other alternative options. We might have some tracers, some monitors, material support for the patient, psychological support. The staff should also be trained. And even with the shortened treatments, a patient that takes an oral treatment and we give it have to be applied for MDR TB treatment we give it for 9 months when it actually should be 18 months. Then it should take so many pills and capsules. So it's not easy to adhere to a treatment. So every drug has a side effect. So we We need to make sure the patient follows or adheres to the treatments, all the tracers. And talk about patient communication includes household visits that they need to be done to see the environment for the patient, see how many people live in the same household, investigate and treat those with the context. And also we may have some phone calls or maybe some text messages. This is also very convenient and effective. Drug monitors are not very commonly used in Mexico, but it's just a little bottle that and the cap has a digital system. When it monitors how many times we open this bottle. Personally, I don't think this is ideal because I can just open the bottle to record it and then just drop and flush it down the toilet. So we rather have other kind of monitoring. We may have some audio reminders or little text messages reminding the patient to take their medication. And also the text messages have been associated with a higher rates of treatment completion. The promoter sends out messages and asking them how they're doing and remind them on taking the medication. We see better rates of success. So there's the outcome of the treatment improve when we include patient education, supplier or healthcare professional education, incentives and facilitators, and when we also provide psychological support. So the more factors we include in our program, the better the outcome. In Mexico, we need to consider that a patient, usually they need to stop working. So it brings up another financial situation for them. So the catastrophic costs generally do not include the fact that patient had to stop working. So they really appreciate financial support or food support, like maybe through some pantries, some food supplements, or some maybe food stamps. In some of the countries, there are some support for the transportation because they have to go back and forth to the clinic to take the medication or for their monthly checkups. So in some countries, there are some transportation supports, and we don't have that in Mexico. Also, we need to have some grants or some supports, incentives for their living conditions, better ventilation and lighting in their homes. There are some financial bonuses for people, for maybe for the elderly, for the unemployed young people. However, we don't have people living with TB. They don't get this kind of financial support, which probably would be more beneficial to give it to TB patients than unemployed people. So we also have to remember that staff education is key if we want to be successful. In many of our health units, that the staff is not well properly trained, or they're rotated constantly. So we train our staff, but 6 months later, they are moved to another area in the healthcare system. So this staff rotation is an issue, but we can also work with a peer training. I'll discuss this later on. Also, the staff training is also shown that it's associated with higher success rates and more adherence to the treatment. Training does not include this, but also we need to train the staff to make sure that how not to get infected. So they need to learn how this infection is controlled. For instance, on these pictures, you can see how they are doing a checkup, how they are making sure fastening the masks, because our faces are all different, so the mask cannot fit us all the same way. So we need to adjust the mask to make sure that the staff is protected. Psychological support is fundamental. MDR-TB is a chronic disease with the limits possibility of the patient, their physical activity. So it frequently is associated with depression. That's why it's also good to have peer support systems or this peer support and counseling on TB is is a process for supporting the patient who makes the decisions in order to reduce the risks of spreading the disease. Adherence to treatment and the mobility of social support needed to make sure the patient can overcome all obstacles that keep them from completing their treatment. In some countries, there are some associations with people who are accepted who live with TB. In Mexico. Due to the stigma of TB, this does not occur. We have been trying to create this kind of patient organizations and it haven't worked because they might be a couple, but they are not working properly. For instance, in Latin America, I personally have seen very successful groups. For instance, in Peru, this group, ASPAT, the director is a guy in the center. It was founded in 2005. And the purpose for these groups is to share experiences. This is when we talk about peer support. When a person is infected by TB and has been cured, and it can be next to other patients who accompany other patients throughout their journey towards health. So they come up with the strategies in order to support their members of the community who are going through the same thing they did. So for instance, ASPAR, they actually lobby in the Peruvian government to get benefits for people affected by TB. In Mexico, we urgently need these kind of groups. As for treatment, directly observed treatment, DOT, is where, because as I said, our system is focused on the system itself. So the WHO guidelines has been telling us how important it is to have DOT for patients, directly observed treatment. Years ago, Dr. Radilla, who is currently the director for the health sciences in Ensenada, and who was doing her master's in public health, she suggested that doing a research comparing the DOT versus self-administered treatment. And what she saw on the DOT, on the Mexican DOT, it was the flexitase. Everyone's familiar with that. When we just give the patients all their pills and said, okay, come back next week. And then we just believe them that they will take their pills. So this is actually sad and not DOT, because we said that during this research with almost over 700 patients, so there were no differences between the DOT in quotation marks, and self-administered treatment. So if we're gonna have a DOT treatment, it needs to be really observed. So this, we cannot follow self-administered treatment regimes anymore. So there's a lot of evidence on the literature on the effectiveness of these DOTs. So we have also found some resistance from human rights associations, because they are telling us that how is it possible that we cannot believe the patient that they will take their medication and then they need to be babysat. Unfortunately, a good number of we do have those measures, we have better outcomes. When we have compared treatment, compare DOT versus OT, and or rates of success for treatment, when it's a real, an actual DOT that is being used, not the flexitide, but an actual DOT. SAT does much worse, lower adherence rate. And this is very important to see higher rates of drug-resistant. Even a drug-resistant patient becomes even more drug-resistant. So without a doubt, despite all the complaints from human rights commissions, we need to supervise treatment, and we explain patient, and the patient will understand that this is for their own benefit, for their own good. Now, there are many ways to supervise treatment. Treatment could be supervised by the doctor, by the nurse practitioner, healthcare provider. It can be supervised by promoters, health promoters that go to the communities, may have community volunteers. And lastly, you could even have a family member do this. However, when we compare DOT by promoters versus family members, the latter is associated with lower rates of adherence. Because this, to begin with, their family member may say, okay, don't take it because it upsets your stomach. Or the opposite, okay, you know what, they have conflict in the family because they're insisting, then please take the medication. So it's not advisable to use a family member instead of a health promoter. A volunteer's health promoter, or maybe a health promoter by the Ministry of Health. When we have this in the community, when we take the medication directly to the patient, for them to take them at home or in their office or whatever, because after a while, when the patient is negative, they may start working, they may get back to work to try to eliminate or reduce this catastrophic cost that I just mentioned. So when we compare DOT in the community and then DOT at healthcare unit, we associate the community treatment at a higher success rates. And by the end of after 2 months, and also lower rates of failure and lose of or lack of adherence. And when we compare video DOT, it can be it's comparable to the traditional DOT, because still some people are afraid of using video DOT because they might think that it may not be real, but we have compared video DOT versus traditional DOT. Video treatment is just as good as effective as the other one. So the WHO actually has guidelines or some recommendations on how to use digital interventions to reinforce the health system. And basically, what the WHO is telling us is that if mobile phones, cell phones are not today part of your health strategy, then you should review your health strategy. Here in Tijuana, Dr. Graciela and Dr. Cordero, who are part of second jurisdiction too in Tijuana, they have over 1,000 patients who are being video dot, and it works great. I can tell you because my patients, my drug-resistant patients, about 100% are being supervised through the phone. And sometimes the patient is an old guy, an old lady, but they might have some, I don't know, grandchildren that they might be able to help them. So there are some commercial programs for supervision that can be very expensive. We have done it through WhatsApp, and it works just fine. So my advice is, yes, you should use mobile phones, cell phones. If it's a part of your strategy, then it should be. You should have done it. You should have done it, since a long time. So another important thing for the comprehensive management of patients that we tend to overlook is nutritional support for patients. Most of my patients with TB, with MDR TB, they are malnourished. So in all the hospitals, there is a nutrition department. There is one at my hospital, so where we get support from them in order to improve the nutrition for all of them as well, at least as much as we can. So let's remember that there's a bidirectional causing factor between malnutrition and active TB. So malnourished patients, they are more likely to develop active TB, and TB is more likely to malnourish or make the patient malnourished. So we need to have a screening and evaluation and management of nutrition as to be considered as very important components for TB treatment. So the message from today's presentation is we cannot just give them pills. Most of the doctors, at least, we think, okay, I'm just giving them the medication. That's good. We're doing great. Well, we tend to forget the rest. And we must remember that pills will not heal or cure the patient by themselves. We need to have a comprehensive approach. Poverty and food insecurity are cause and a consequence of TB, both. So it's very important that those of us who are working with patients with MDR TB, we need to take this into consideration. And we should get support from the specialists at our hospitals in order to prevent this from happening. TB also is associated with comorbidities, as I mentioned, comorbidities that may also lead to malnourishment. For instance, HIV. Unfortunately, many of my patients, they show they are diagnosed simultaneously with TB and HIV, but diabetes for us is a nightmare because patients are not well nourished. Now they keep drinking soda and eating pastries, despite the fact that they have diabetes. So it's not common that we see patients with severe complications. So this is very important. It should be looked at. When we see in the weekly meetings that we have in the advisory group, is investigation, the contact tracing in Mexico is something that has been left behind. It's become a secondary element for treatment, and what we consider as contact tracing here is we just come up with a list of all the contacts, and that's it. And we think that's a contact tracing. No, contact tracing involves having a physical checkup, some surveying, some testing to see if the contacts have been infected or not. So you see, in the contacts in Mexico, it's not very uncommon to see and say, okay, they have a contact. Okay, we say, okay, they have. It must be a caveman. How's it possible they only have a single contact? Most of us have several contacts on our daily lives. So this contact research has been divided by household contacts, work and school contacts, and leisure contacts. So depending on the number of hours the patient spends with in each of these groups, they consider low, mid, and high risk. So we should need to analyze 9 groups of contact. So I would be very pleased if we at least investigated the first group. People living with a patient in more advanced patients countries on TB control, they investigate all 9 groups. And we might think, no, Americans, they overreact. No, they're doing the right way. That's why in the US they have a rate of less than 3 cases out of 100,000 people, not because they are expensive, because they are rich, no, because they have invested in contact tracing. So that's why we should start doing this. And it should be done properly, and it's not being done. So one of the tools that should be considered or used for contact tracing should be thoracic X-ray, especially now with AI, because now there are some software that might help us interpret X-rays if the doctor is not very familiar with it. X-rays are digital to begin with, so they should be part of your tools. And we should also have an algorithm to be able to investigate each contact and comply with this. Because I don't know in other countries in Latin America, but in Mexico, we love complex algorithms. Those will have 30 or 40 little boxes, but no one pays attention to them. Here, as you can see, we have an algorithm for contact tracing by the WHO. It's super simple, right? They said ask people in the risk groups if they have any symptoms. If they do, then they are researchers. If they're studied as if they were patients, they were sick, and if they don't have any symptoms, then they are tested. If they are infected, if they're negative, they are reevaluated after 3 months. If they are positive, they do a thoracic X-ray, and if it's abnormal, then they are researchers or investigators if they were sick. And then if the digits is negative, they are treated as latent infections. So it's very important. In addition to the context the patient has at home and other places they may frequent. Also, the healthcare staff, because we are also contacts. And infection control in healthcare units, it has been abandoned. Wherever we go, it's very rare to see the minimal standards to protect the staff. But there are 3 levels of controlled infection measures or actions or minimal that should be followed in every healthcare unit, and the most important and the less important is for the management, for the administration staff. And basically, what we do, we screen people when they come into the hospital to make sure that they don't have TB, and if they do, or we suspect that they do, we isolate them so they don't infect or they don't spread the disease, and we treat them. We treat them to avoid. We can also have some engineering measurements, good ventilation, UV light, and so on. And also the masks, the use of masks. We see there's some healthcare providers that use paper masks that they really don't work at all. So what we need to do is we need to emphasize this, because in the Luz Verde committee, when we go to the countries in this region, they have always had TB patients in their staff. It may vary, but every year we identify a very good number of patients with TB as part of the healthcare staff. In our region, we have had this experience, for instance, in a research we did conducted at the General Hospital in Tijuana. The incidence rate among the staff, it was 439 out of 100,000. Not even in South Africa they have this rate. So we are at serious risk. And actually this rate, as it says, 11 times higher than the rate in the city of Tijuana. So it's something that has been ignored, how we should need to protect healthcare staff. We're not also talking about doctors and nurses, but we have technicians, people who bring food to the different rooms. So everyone who works here. And another thing that has been ignored is active drug surveillance. I'm not going to spend a lot of time on this because this would make me expand for a long time on this presentation. But what I'm trying to say by this is that we should ask patients their side effects or adverse effects of each one of the medications they are taking. Until recent years, if the patient would complain, they would say, okay, you wouldn't even take note of that. Now, today, if I am giving them linezolid, I need to see how the hemoglobin is, routine checkups, and check their eyesight. I also need to ask questions about peripheric neuropathy. We need to check the sensibility of patients. So we need to actively investigate adverse effects. Why? Because adverse effects are what make patients drop treatment. There's a time when they don't treat them, it's worse than the actual disease, and then they just disappear. The patients, that is. And so lastly, something that I don't like to be able to I don't like discussing, but it's very necessary, that in other countries, There are patients to go to healthcare in Mexico, in the Ministry of Health, and they come in very late. Patients that have been treated or mistreated by others, and when they come to us, is very little we can do. Their lungs have been destroyed. Their resistance profile is so high. We have a patient right now. I'm not gonna say where she lives, but this woman, we didn't have any options for her. So this poor woman. So instead of just abandoning these patients, we need to give them some effects. We tend to say, okay, don't come anymore because there's nothing I can do for you. I don't have any medication to give you because you're resistant to all of them. So the patient just goes by themselves, and what can we do? And we need to try to support, to help them, to help people breathe. We might get them oxygen tanks, so we need to do all the paperwork for people so they get oxygen tanks at home. So these patients, they have pain, they have other symptoms. So pain should be treated, nutritional support, as I mentioned, and also we need to have regular checkups with them. We're gonna give them a monthly checkup to see how we can help them. So also social support. And lastly, we need to respect their beliefs and their values at the end of their life, whatever the patient decides to do with their life. And of course, infection control. Infection control is very important to protect their family members, their friends, their neighbors. Because usually these are patients with the bacillus disease, highly resistant strains. So I hope that now that those of you who have worked with MDR-TB, you ask yourselves every day, because I ask myself this question all the time, and I know that some of these elements are not part of my program, but I need to remind you that there are several things that comprehend a patient-focused program. See, we are being ethical on our on the way we deal with patients. Do we have methods for ideal disease diagnosis? So bacilloscopy is definitely not the best option. It's not a current method of diagnosis. We have molecular diagnosis. There are some medications that we don't use anymore. So we need to make sure that we give them the right and current treatment. We have social protection, counseling. Are we actually drug surveilling our patients? Infection control for their family members and the staff at the hospitals. We need to also fight the stigma. So do we have anyone that might help us with the last treatment for people in the end of their life? Are we working transversely with diabetes and HIV programs and the nutrition department? So ask yourselves, if your programs have all of this. If they're not, then you're not patient focused. And then we can expect very poor outcomes. As you see in a region, the success rates are a little above 50%. So for those who want to change and update their program, the question would be, where should I start? You can visit this website as a free WHO website. There is also a WHO page. Sorry, my slide is running very slow. This is WHO website, which is free, and you find all the WHO guidelines for TB treatment. That's what you can see on the screen. All these guidelines are consolidated, all the operating manuals, because there is a catalog for training manual. So if I were you, I would go there and you can document yourselves and educate yourselves on what you can do to make sure you are patient oriented. So with having said this, I want to thank you all for your attention. Then Dr. Muñiz and Dr. Pulido, I guess we move on to the Q&A session, if there are any. Thank you, Doctor, for your interesting talks and presentation. Yes, we're open now to questions. We have many questions for you. The first question for Dr. Laniado is, in case the patient cannot come to the clinic for the treatment, have we implemented a way to take the medication to the patient's home every day? Yes, it depends on the jurisdiction. Here in Tijuana, Dr. Cordero, she's responsible for this, and we have direct communication with her every day. If a patient does not come, we go and call them, and the patient may not be able to come because he's sick or whatever. So, despite the fact that we have very little promoters and we don't have enough resources for the transportation, patients always get their treatment. And with the video dot and video SAT, patient can use once a week, and every day they record a video and they say the date, they show the medication in their hand, they swallow them, and they drink the water in their mouth to make sure that the medication is not in their mouth, and then they send the video to the promoter. So the promoter, instead of having to move around the city, they can supervise 5, 10, 12 patients every morning. So there are ways, and we have to make sure that patient takes the medication where it's more convenient for them. We usually they're in their home. Yes, I think all the jurisdictions we suffer from this. We face the same need, but it's good to hear the strategies in Baja California to make sure patients take their medication. The next question is, where do we do patient education chats or trainings? Yes, usually it is done by the staff from the department, healthcare department. Here we have had some promoters while they wait on patients wait on for their appointments and the waiting room. We give them short educational talks, so patients are more informed on their own disease and they are more to treatment. Yeah, sometimes when we have a promoter, we use there's other barrier for the creation of a group such as Sparta in Mexico. I think the stigma is the most important one, because in my conversation, I always ask them, how come we don't get together and we organize support groups for people with tuberculosis? And they said, no, doctor, I don't want anyone to know that I live with TB. So the stigma is the major issue, the discrimination. Discrimination is important. The way TB patients positive, how positive the group can be. In HIV in Mexico, there are multiple groups of people living with HIV, and they lobby hard against government to achieve some quick diagnosis methods, some quick testings for HIV. Now they are available. It can be done anywhere. They're all over 30%, 30 different medications for HIV. Now they have evolved. Instead of having to take 20 pills every 2 hours, now there are some patients that take a couple pills a day and they are doing fine. And it has been done not because thanks to the government, but it has been done due to the pressure exercised by these groups. So we should have the same. We should support and push the government to take action. So you think the stigma is also one of the causes for the low contact tracing in this patient? No, I think basically it's people are lazy. Yeah, the staff is being lazy. We diagnose a case and we diagnose TB and we want to control it with a system used back in the 60s. You just diagnose the patient passively and then just treat them, and that's it. But it turns out that we forget that the disease can be spread. It's contagious. But with pulmonary TB, they infect 20 people. And those 20 people, out of those, 10% will develop TB if nothing is done, if they are not diagnosed and treated. So a case generates two. Those two cases will infect over 20, and they will generate, and each one will generate two more. So one case generated two, there's two generated four, and we have this snowball effect. So we'll never have enough nurses and doctors and medications because we are not going to the root cause. We're not cutting the chain. That's what Americans do. They said, okay, we're going to treat patients properly. But they did is an intensive campaign for contact tracing and treatment for those contacts. Because if the patient, which one when they're infected and they don't develop the disease, it's fine. They don't spread the disease. In the US, for example, a kid, a school teacher catches TB, they study all the students, all the teachers, all the people at the kitchen, the school bus driver. But here, if we find someone, we hope that no one else develops the disease. And this is key. Active detection of TB. Instead of just sitting at our desks, we should go out to the field at high risk or hotspots and have active diagnosis. For instance, prisoners, people that's living in jails. We need to be more active because TB rates in prisons are much higher than the rest of the populations. So we need to identify the cases and treat them. What are the stigmas in Mexico related to TB? This comes from a long, patients with TB, they forbid us from telling their family members that they have tuberculosis. We don't do that. Obviously, if it was not an infectious disease, we wouldn't tell the patients, but I cannot sleep at night knowing that I didn't protect the child from catching TB because I didn't tell the family. We shouldn't have this stigma. It's due to lack of education and the health care staff and the patients. We need to have an intensive campaign for awareness campaign about tuberculosis because it comes with a moral burden. Even people who caught the disease because they're alcoholic, it doesn't matter. They are sick. You shouldn't have a moral burden. People living in the street, they get the same treatment. How do we do that? No, the homeless around the world, they're an invisible group for healthcare systems. And when we ask people, and then what's going on with the homeless? No, it's so difficult. Yeah, they're gonna die anyway. So no, that's not true. They are on the street. They are spreading the disease. Some things can be done, but it requires a bigger effort. For instance, here in Tijuana, all the people, all the homeless, they need to be, all of them, and there are certain places in the city of Tijuana, La Casa de los Pobres, Parque blah blah, where they give breakfast, they serve meals. We can go there and diagnose them. We can go and treat them. There's people who like living in the street, and that's okay. They can decide whatever they want. It doesn't mean that they should be forgotten. But it's not a problem exclusive to Mexico or Tijuana. This is a problem around the world. So what do you think about those programs? Supervise patients weekly, and we allow patients to take. No, that's not going to work. That doesn't work. If we don't have DOT, it's not going to work. We want all pills to be taken at the same time because they have peaks in the blood. That's how the medication works better. So if you take it three times a day, if patients develops gastritis due to the medication, we can find different ways to help them. We can use some blockers. They don't have to eat it before meals. There are different strategies to protect the patient's stomach. So you say, I'm going to give you the medication and you can take them anytime you want, then things are not going to work. was the initiative strategy to prevent healthcare workers from being infected. As far as I know, none of them. This person, the healthcare staff, they should go see the patients. Instead of waiting all the family of the patient come, we need to have a household visit. And they need to go with they should go and see how many household contacts there is, how many people are at high risk, children, diabetic people, the elderly, and we should investigate them and treat them accordingly. So this should be done, but we're not doing it. Because as I told you, every week we have meetings, and when we ask for contact, yes, we did contact tracing. We said they haven't been examined, they haven't done any TB tests. I'm not going to talk about egregs, but no X-rays have been taken. Obviously, they're not taking medication, and then we are surprised the fact that TB rates. Fatima probably presented this TB rate in Mexico. The incidence rates hasn't dropped in the last 15 years. It went down during the pandemic, and it went up again. It went down during the pandemic because of lack of detection, because we were not able to leave the house. But to reach the WHO goals for 2050, we should, as a region, we should drop 11% a year. And Mexico, we're dropping 0%. So some of the regions we go to, as Mexico as a whole, is lowering the rates 2.5%. We're not going to meet the goal. In Baja California or Tijuana, how many TB groups are? TB support groups are? None of them. So according to your beliefs, you think there is higher, depending on the beliefs of the patients. What do you mean? Religious beliefs? I don't know. That's what the question says. Okay, the medication works for anyone, whether you're a Jewish or Catholic or whatever you are. Yeah, the medication is it's not gonna interact with your beliefs. In the last 6 years, the WHO is telling us that replace bacilloscopy by the molecular test, and it's not because of business. What are the advantages? Bacilloscopy is sensitivity. Or not Esper, tell us in an hour, 45 minutes, and tell us if the patient has TB. And they'll let us know if they're MDR. And their accuracy is 98%. And specificity is 96%. So why are we still doing bacilloscopies in Mexico? Is because the TB program has been abandoned it's not getting enough budget. They want to become magicians. And no, you organize yourself. We're organized, but no matter how organized you are, but if you have enough resources, there's nothing you can do. You might be very well organized, but if you don't have enough resources, there's nothing you can do. So, yeah. We should stop using bacilloscopies. We should use molecular tests. The present for TB diagnosis is molecular. Bacilloscopy should be left up for follow-up every month to see when they are not as infectious as they were before. But for developing, we are using a test for diagnosis. We're using a test that has been around for 130 years. So what efforts are being done to educate healthcare providers in the Mexican healthcare system? No, go to medicine schools and ask how many hours spent on tuberculosis and medicine students. We tell them about a bunch of medicines they will never see, about a bunch of diseases they will never see. General doctors are not going to deal with leukemias, but they spend a lot of time talking about leukemias. They should talk about diagnosis, how to diagnose TB, how to treat TB. So, because we're in a country with high rates of TB, So it should be part of the curricula at this medicine school. Spend more time talking about TB than rare diseases. Thank you, doctor, for your participation. No, thank you all for your patience. Well, this event is being supported by Vamos Support in Sucursal and offices in Centro, Tijuana, and distribution nationwide. As an instance, there was a headquarters in Guadalajara and some other offices in Ensenada, and its products are distributed nationwide.
Aquí sepa para decirle que estamos en comerciales.
Commercial break.
Mendoza, médico cirujano especialista.
Now I'm going to introduce Dr. Alberto Mendoza, Medical Director at the Oscar Romero Center and Epidemiology Clinical Research in the University of Peru. As I mentioned, he's a Medical Director at the Oscar Romero Center by the Socios in Salud in Peru. He's also the UPS consultant on TB infections for the countries in the Americas, as a member of the science developers by the U.S. Health Department. And he also works for the WHO. He will present a talk about TB active search strategies and the drug-resistant TB situation in Peru. Thank you, Doctor. Good morning. Can you hear me? Can you see my screen? No, we can see you. Okay, I'm going to turn off my camera so we have better connectivity. Today's talk we need to develop some active search strategies for TB, specifically in TB. I'm going to give an example of things that have been done well and what have been done wrong in Peru. And so we can share experiences. And we will be talking about TB control, some examples, very useful examples of active search for TB. I'm going to talk about a little bit about MDR TB. Can I show you this? If this image reflects the work done by some people in the community, these are their mothers and their families, and they spend their own time, housewives. They go around their community to work and to have an active detection of TB, identifying people with probable cases of TB. So these people, they're not very knowledge, and as part of the healthcare system. We can see they play a very important role. These are volunteers. They don't get any money for this. Sometimes they just get a vest and a little pin is enough for them to go outside and spend their time fighting against tuberculosis. So as I said, some of them are housewives who have been affected by TB, and they want to help the community from their own perspective. The state tries to train them and supervise them. And I think a lot more can be done. This is an example. This is something that can be shown in other countries. So let's define the concepts. Rafael mentioned very well this comprehensive management. He gave very good presentation that we're going to use this as a foundation for my presentation. So when we talk about TB, let's imagine there's a fire, we need to put out the fire. Otherwise, things are going to get out of control. We need to follow the detection, diagnosis, and treatment. We need to detect the disease actively through active screening. And then we need to find the probable cases of TB that used to be called suspect cases. We should not call them suspect cases because of the stigma and discrimination against them. Now, they are not suspect. Usually a suspect, someone who has done something illegal, something wrong. So we need to change that when we talk about TB, probable TB. And when we need to work on a diagnosis, which is a very important part too, because in the probable cases, we might have a specific intervention to have a defined and definite case. And that's when we usually have tests and identification nucleic acids that, as Rafael mentioned, they're present when we need to stop using old techniques and focus on the current techniques. And then on the treatment, yes, we need a person who has been diagnosed with TB. I need to treat them and help them heal. We have the strategies such as DOTs, and so on. And prevention is when there is a fire, but we don't want to have a fire again. We already put out the fire, but we don't want to prevent it from happening again. So usually here, it's done through, we need to talk about primary strategies, maybe avoid infection because we were born without TB. That's why we need to. Vaccines are one of the major ways of preventing. We're working on developing new vaccines that are more effective. And BCG. Secondary strategies are very happy. We have a lot of success here. We have to avoid the disease, or prevent the disease from happening in people and already infected people. So we have the PPT or TPT. We have some schedules for 3 or 4 months and tops. They're still effective as longer schedules that we had in the past for 9, 12 the months of isoniazid. So the third strategy is to avoid side effects or any consequences and death on people. We're going to do the same thing here in a graph. So we have a population, we need to focus on risk populations. As I mentioned, the most important ones are TBP contacts, those who live in the same household as the patient. Those are a high risk of having probable or confirmed cases of TB. Of people living in prisons, hotspots, immigrants, indigenous people, homeless, people living in extreme poverty, HIV positive people. See, in red, we see people living with TB. In blue, people are healthy, maybe infected or not. But those who have red circles around them, they have the disease, but they have not developed the disease. So this is what you see, probable TB screening. What it gives me is we have this health population right here, and we have TB probable population. That's when I intervene with a diagnosis strategy with an X-ray or sampling code. And this is will tell me cases are not TB and TB cases. And then we start working with treatment. And then we have here cured and non-cured. We want to make sure that 100% of patients are healed, but that's not the case right now. In this intervention, when we look at prevention, people, non-TB cases, we need to assess the possibility of offering TTP. So very often this part, this initial part, is not very clear in our program. We don't have it's not well defined. That's why it's so important to understand them. So the WHO provides a lot of information on prevention of how the screening guidelines, diagnosis, and treatment. But today we're going to focus on these guidelines, these detection guidelines, screening guidelines. Very little is discussed about them. So I'm going to show you this chart. You can find this in the guideline. It's very important to understand it. It's going to evaluate the accuracy of the screening. So part of this, we had a screening test according to the WHO, has a sensitivity higher than 90%, and specificity of 70%. So when we have the symptoms such as prolonged cough, 2 weeks or more, sensitivity is only 42%. So we're going to miss more than half the people with TB, and specificity it can be low, 0.94%. So for this phase of screening is not very useful. That's why it's so important to work in the region. And okay, then we have these symptoms, then we do a oscilloscopy, that was the detection 42%, and the sensitivity was below 60%. So we're under diagnosing people. A lot of people were undetected. We're actually treating a very small portion of the population that are actually infected. So when we keep analyzing any other cough symptom, cough, hemoptysis, fever, night sweats, weight loss, the sensitivity goes up to 71%. Specificity, it goes down 64%, and we see chest X-ray, the sensitivity goes 94%, and the other value goes to 89. And when we have an X-ray, chest X-ray, suggested abnormality, this is suggestive abnormality of TB, then the sensibility goes down to 85%. So if we don't think we are not using X-ray as a tool for fighting TB and the screening TB, we're not going to be able to move forward in the control of TB. We won't be able to move on to the diagnosis phase, and that's going to have an impact, of course. So systematic screening is to actively look for TB. As we see, if TB prevalence in the area is 0.5% or more in people. So because we need to identify symptoms, we need to have a symptom algorithm, chest X-ray. So we suggest using X-rays because the other alternatives can be more expensive. Another important intervention is having CAT diagnosis. This is very important, especially in cases we don't have radiologists. The doctors cannot read chest X-rays very well. So there are some systems, some software that help us with this AI algorithms that give us a very good distance, and they let us know if there is any abnormality on the X-ray. And we cannot say that this X-ray is enough. I mean, detection doesn't mean that we're ending the problem. It just means that we might have to come up with into a more specific diagnosis method. And we need to continue with X-ray if we identify anything abnormal, and we need to work on C-reactive protein. If we have a value less than 5% with a person with HIV, we can have to watch very closely for TB. The people living with HIV, right away we need to do a chest X-ray and check their C-reactive protein. And if the X-ray is fine and PCR is lower than 5, then we said that the chance of not getting TB is very high. So this is reinforced by the 4 symptoms that we all know very well: cough, fever, weight loss, and night sweats. These were very fundamental values or symptoms that we need to watch out for. So we have this screening program models. It's set for it by, people. First stage is when people that come to the healthcare system and then for their checkups, and we identify this. This was done in the past. We also have occupational screenings at factories or prisons or places hosting refugees. Screening at home, that's especially done for contacts. Then we have mobile outreach screening campaigns that go out to the communities with this sort of mobile vehicles, mobile units. And obviously we have the health fairs. So these are all active TB detection strategies that we should apply to our realities, and these will help us identify TB cases. For instance, if we have symptoms, respiratory symptoms, and those people with those symptoms, we do an expert, we're going to detect only 36%. This expert changed by the Ricardo's vacilloscopy is going to drop to 20%. And this is a model we have been following for a long time in many countries. Some of us, we still do this, having this respiratory symptom program, and that's not screening, and that's not way. We do a couple of vacilloscopies, and we are actually detecting very few cases. So the more devices we have, chest X-ray and the respiratory symptoms, and then we might get 84%. And this sequence is a sequence. If we have prolonged cough, and we have molecular test, and if possible we have a positive or abnormal chest X-ray, we might be able to identify 84%. Other ways to using any tuberculosis symptoms, not only respiratory symptoms, and these might also help us get more than 80% of detection. So the recommendation is to use an algorithm, and TB symptom algorithm, and then if it's positive, they should have an expert test, and if it's negative, let's in the context, let's do a chest X-ray and see if it's abnormal. We go back to molecular testing, and if not, we can have an TB preventive treatment, and then we will be able to identify 85%. We cannot expect right now being successful in this battle against TB if we start thinking about the use of chest X-rays. So now people were using exclusively vacilloscopy, and that's a big mistake. We're actually using again digital X-rays that has been helping us. So it's very good. For instance, in very hot areas, it's very good to do a chest X-ray for all the population to be able to identify any abnormalities, and then do a molecular test, and we were able to have an identification rate of 80%. So there's more evidence on AI and its use on tuberculosis. So this evidence is a provider, and is a Dutch company that created CAT for TB. And then we have the digital X-ray put on the web, and I think they charge 50 cents of a dollar for each evaluation of an X-ray. So they give you a heat map and the evidence of a person, or this particular patient having active TB is 78%. And so you can know in real time, in 20 seconds, you can have a digital reading and you can make a decision. So this is an example I want to show you the use of this application in Lima. Lima is a very large city, very large of a victim of terrorism in the 80s and 70s. So lots of immigration from the other states of the country, they move into the city. So we have several social issues here. So this is an area in the Caraballo district. We have a very high transmission rates, a hotspot. And we identified the district with high transmissibility rates. We have even 320 cases out of 100,000 people. So we need to have a focused active TB detection, and we use these mobile units. And then we would go to open spaces for the target population. We do a digital X-ray regardless of their symptoms. And then if it was normal, that was the end. A normal, the definition of normal was not decided by just a person. We would have some technology for do that. We would do, if it was abnormal, we would do an gene expert. They would have a clinical checkup by general doctors, and they would define if it's gene expert or not. They would determine if someone had any TB, was a TB case or a non-TB case, and they would continue with treatment. This system, as a desktop system, is a digital X-ray that is read by this system. This Fujifilm. This, you buy the AI for this program, and they help us read these X-rays. At the beginning, it can be expensive. It's a big investment at first, but then it pays itself. So this gives us the probability of giving us 80% of a TB case. So with this patient, we do a diagnosis test. We take some spit samples. It's a very important test. And then we do the expert test and expert ultra to get results in 2 or 3 hours and see if the patient would be admitted or not to the TB program. So many things have been learned throughout in our journey, but generally speaking, I can tell you that it's very important to have a political commitment. This was presented by the mayor of Lima, and she's the Ministry of Health. And this is the director of Socios de Salud, where we were able to analyze that we conducted 31,290 detections in hotspots. We took 28,000 X-rays, digital X-rays, 88%. And 26% were seen as abnormal. We conducted 6,425 expert tests, and expert positive was 2%, and rifampicin resistant TB was about 10%. And total, we diagnosed 155 cases. The difference was patients and children would have clinical tests. So we did some clinical tests, not only the regular X-ray. And out of those, 79% received treatment in our unit, in our health system, and the rest, they did not, for different reasons I will explain to you right now. So important is we have an incidence rate of 489 cases out of 100,000 people. So for TB in these hotspots, there was a high probability of a large percentage of people, they had some traces of a very low traces detection, and the healthcare system are not very familiar with the expert. They did not validate this result. They would only use the vacilloscopy. Of course, this was worked with together with the local health system and in order to improve this. So we would have an X-ray evaluation, a clinical evaluation, a bacteriological evaluation. We would detect 155 active TB cases. So we have the clinical assessment and expert ultra as an important tool for diagnosis. Something very interesting is throughout time, this is triggered because we started seeing intervention and we identifying when the healthcare system was identifying the patients with vacilloscopy, intervening actively in the community. We identify more cases than they were identified in the past. So what we have seen, we learned from this is how we are making sure the community take part in this effort. And this had to do a lot with intervention. We had to intervene with youth groups at churches. We were giving out flyers in the community explaining people what this meant for them. However, what are we doing? What can we achieve with this? What the community is telling us, if you have prolonged cough over 2 weeks, then you know that that's an homogeneous message of open the windows, have a good ventilation, eat well, exercise, and the new messages is that TB is everywhere. You should be screened, and you have the right to be diagnosed, treated properly. So changes are the messages are evolving. We want to get people make people realize that they are part of the solution. They are not a passive. They don't play a passive role. They play a very active role in their own health. So this is there were things that we need to learn, because we make sure that all the cases identified through this program, we would need to have timely treatment. But for instance, the healthcare system would say, no, these patients seem to be healthy. We shouldn't do that because we need to identify other reasons for them to lose weight, and they didn't want to act promptly. Even though there were some indications that they might be possible cases of TB. We need to make sure the people receive an attention, the preventive therapy right away in order to reduce the possibilities of developing TB. Then we will go and talk to the healthcare system and say, because the healthcare system was not ready for receiving the amount of patients and the number of contact tracing cases that had to be done. So we need to work on this to make sure we have enough capability for this. And we need to see that the ministries of health, they have enough resources for guaranteeing the attention to these cases and the contacts. The challenges, it's very important to have to work with the community, fight the stigma. We need to have at least 180 X-rays for in each location to make it more cost-effective, and also identify some qualitative assessments. If people were interested in having comprehensive fairs, because they had a single TB fair was very difficult. Not a lot of people will show up because as a stigma, as we mentioned, they don't want to go. If I go to a fair that I know people are testing for TB, then people will know that I have TB. So also we could work together with uterine cancer or different other fairs that we can hide TB testing. So what matters is that we need to have a diagnosis and the outcome. We need to work at that. We need to work better with healthcare providers, so they act on what is being detected by the CAP. So we hope that the government takes action on this, because we need to have some cost effects researches to make sure things work. And we should actually invest on such a serious disease that affects so greatly in our communities. We need to give them evidence of the importance of treating this condition. Something has to be done. So people take this serious and start financing these kind of efforts with federal money. So we have developed publications on this experience. We talk about the role the community plays in this, not only about based on the history, but we said that, let's say, it's a collective research when we did engagement with the different people that are leaders in their communities. People that would come, that work in the community and they're well known in the community, they would help us to spread this information. And then also the geospatial analysis of reported activity locations to identify sites for tuberculosis screening. We determine the distance between the homes and the patients and their clinics. So identify the places where were best for the mobile units. So I would suggest you go check all these documents are very interesting. So we have also Mochila TB. It's an intervention effort when we are working. Sometimes vehicles cannot go down on those little streets, so we go by foot and we do the same screening, and we carry the equipment in backpacks. And we're working with health promoters in the community. So we're gonna talk very quick about drug-resistant TB situation in Peru. These are the curves since 2008 and last year with TB patients. MDR TBs, you can see here, and XDR. So obviously the numbers went down during the pandemic, but generally speaking, the trend is always upwards. So we're not doing, the graph is telling us we're not intervening as we should in order to control this. And in Peru and in other countries, we have taken some much effort into this, but apparently we're not going to the right direction. We want to flatten this curve. And this is, for example, as one thing that we want. This is the notify the percentage in the last years. 3% are XDR, 62 are MDR, 7% are rifampicin resistant, and it's 27% are INH. So we compare this to the numbers from the 2015 when we see a certainty that the reality is this, because it was a large sample was taken. We see that half the people are resistant in Peru are resistant to istamicid. So it might very likely that we see the same thing in other countries in the region. We're underdiagnosing resistance to, especially with expert detection relative rifampicin. So this might be going on their diagnosis. 6% are rifampicin resistant, and we have MDR on maybe 5%, or 5% is XDR. But what I'm trying to highlight, we're underdiagnosing in Peru, for instance, istamicid resistance, and it has to be dealt with. Otherwise, this is a preset of MDR. Because if we don't address this, most likely we're going to develop drug-resistant or all drug-resistant cases. So if we only work with experts, the outcome is not going to be good. So yes, expert is very good, but we can complement it with the X-rays and so many other things. Generally speaking, the cure rate is again from 55 to 60% in IRR, and abandoned rate is 25%, and this is based on treatment in the country. And XCR, it goes high, it goes up 84, 69, 4%. XCR is better cure than MDR, of course, because technically speaking, these are 100 patients a year. That's our treatment. So the state has invested more money in them. Here we're using other medications. The new medications, but here we're using older medication that should not be used anymore. And why are we not changing these practices? It's because it can be very expensive. It's not cost effective for us. So once again, cost effectiveness is very important. It's very valid to do some cost effective research. There are better tools that will help us, especially for more resistant strains. So this is the first recommendation. We have to expand the view. So this is a recent evidence that we have evaluated in research that is being done right now. We have compared the LPA test against a group that were only detected phenotypic DST. Here we can see that in theory these are comparable against those who have been untreated, and here patients with alcoholism. They had a phenotypic DST. First, you need to isolate the bacteria and then do the resistance test. With a direct LPA with a positive result, we think of resistance right away. So what we have seen is that diagnosis time for diagnosis is MDR goes up. TB sensitive is reduced greatly when those who start with LPA against conventional tests. And the time to initiate MDR TB treatment drops to 50 days, from 152 to 50. So yes, LPA is helping us diagnose faster MDR TB. So we want to ask you now that we haven't diagnosed this, is going to have an impact on the clinical side of the patient or not? The theory says it will. If I have faster diagnosis, and we're going to have, if treatment is effective, we're going to have more success rates. But the answer is no. We have talked about the comparison to month six of treatment. We see a little majority here, not a significant difference, but at the end of the treatment, let's remember that these are schedules that were done in the last decade. They were injectables for 18 to 24 months. So the treatment outcomes the changes were not different. So 2 years after, we did follow up on these patients when we are TB free with no relapse. So there's not a big difference. And those who were post-discharge, then they relapsed. We had a very high rate of relapse for those who abandoned the treatment. So the genotype test shortens the treatment and diagnosis, treatment, but it does not have an impact on the clinical outcome. This is in a group of Lima that have high comorbidity for TB. So you have to do more than just diagnose timely. You need to work more. You need to have better system. to treat those patients, because we have to go beyond just providing them drugs. So we have been living in a decade from 2010 to 2020, following these guidelines. 2011, that had this treatment schedule that has kinamycin, amikacin, quinolones, and some other some other drugs, and it has led us to have these kind of outcomes. The follow-up, we have the cure rate that is lower than 50%. So this, we need to keep moving forward, because this should be a lesson learned by us, and we need to do better. Now, lastly, I want to tell you that hope is the last thing that dies, or it always reborns. So right now, we are before a new time. We have better, we are expecting better guidelines that will tell us rapid communication, key changes to the treatment of drug-resistant tuberculosis. Firstly, it says all patients with MDR or RR-TB, even those that have quinolone resistance, they may receive oral schedules, and they should be applied in program conditions. So, meaning BPALM, it combines pilactilina, predominid, linezolid, amoxifloxacin. So it can be used for patients with MDR and RR. So we need to take consideration that there is no budget for these drugs, and we should have without this amoxifloxacin when quinolone is identified. So oral regimens for 9 months, this with bedaquiline, they're preferable for longer for children and adults. So this is a regimen that could be used for patients with TB and GR forms of TB. So we need to have individualized regime, customized regimes for them. So if we have a screening system, we need to use digital X-rays. So we need to introduce expert, and not only that, but we need to find some other expert plus an additional test, maybe some platforms, LPA, whatever, to make sure that this is a TB sensitive case. And then when we find some drug resistance, we need to forget about injectables and focus on the oral treatment. That in 6 months or 9 months, that might give us very good results. And if on top of this, we include all the information provided by Rafael, so telling you that there are 7 messages that you can take home from this talk. We need to understand the prevention control, and there are 3 different levels of prevention. 3 levels of prevention, and the detection, diagnosis, and treatment control. So this is very important. People sometimes don't grasp these concepts, but are very important. Detection definitely is the door for us. If we cannot detect them, then we cannot do anything. So we need to have this very clear. The second item is active detection is something that will be complement passive detection. We don't have to replace it, but they definitely has to complement passive detection through different campaigns and different community efforts, and always using digital X-rays as a tool. Also, there are new tests, new strategies, and new algorithms. We need to educate ourselves. We need to learn about these techniques. We have seen in Mexico, in Peru, we have seen very successful case of success using TB mobile units. Talking about the importance of having digital X-rays, CAT, and expert. Of course, we're facing some challenges that need to work on, but we are in the very good direction, I would say, in this regard. 5 is improving MDR TB cases to all different kinds of medications. Okay, from 2010 to 2020, it was a very bad decade for MDR TB. So we lost follow-up, and the treatment did not take advantage of the diagnosis methods that we had available. There are some people who are not adjusting to the changes in. Some people leave treatment with deaf, and it's a problem for them, and it's hard for them to reintegrate to society. So then remember that hope doesn't die, and if it does, it will revive. We need to consider what Rafael mentioned about the comprehensive treatment of TB. So thank you so much. We come from the Oscar Romero Medical Center. Our saint is San Oscar Romero, who is a Salvadorian saint. In March 24th in 1980, his mother during meth by the extreme right extremists, and that's why he died on the tuberculosis day. So he also worked with the community, so that's why he's our saint for this cause. And that's why we opened the Oscar Romero Medical Center. We want to become leaders in this area for handling and providing information for healthcare providers that are fighting against TB. Here is my email address in case you want to ask me anything. Thank you so much. Thank you, Dr. Mendoza, for your presentation. It was so interesting. Now we are open to questions. The first question for Dr. Mendoza. How often do you do screening on TB mobile units? TB mobile unit was an intervention. It's not scheduled TB mobile, and it's used in case because we need to actively search for TB in hotspots. So there has been a punctual intervention. It's been done in the last year and a half, 2 years, and we have been monitoring different variables to decide where we're going, for how long we're going to stay there. So it has been moved depending on different scenarios that we face, particularly the acceptance of the population, the site where we could locate ourselves for a while, getting the authorizations from the local governments. So there are times we haven't been able to. We want to set up inside a certain park, and the community didn't like it. So we didn't have a good preparation. We improved our preparation. It's not an easy task. So it's not a regular thing. It's something has been on and off, depending on different situations and different indicators. So what we need to do is we need to do community engagement, so we're more successful in these efforts, and come out with research to show them to the federal government. Say, okay, this is why this is so important. So that's basically what is affecting this TB mobile initiative. Okay, thank you. Also, would you go back to previously studied populations, and how often, if you did? Yeah, the intention was to identify the geographic zones that would intervene, and then we identify positive cases. They will refer them to their medical facilities, they would come up with a report with all the tests, the results of the test for each patient, and then we would, most of them start treatment, but in some cases, as mentioned, the doctor would say, no, I don't see any clinical symptoms, and then would do some cultures, and in a country we're not very familiar with expert because it was not properly used. So we go back with the families and try to talk to them. And so we actually right now we're following up closely all the cases and their families, but now that the government of the state is going to give the supplement and is going to support us with contact tracing for family members and friends. In that case, we go back and take X-rays on the contacts, and the government cannot absorb all this.
Okay. Doctor, aparte de la localización de las casas, ¿hubo otra consideración?
In addition to the cases, are there any consideration for using the TB backpack? TB backpack was originated because we had the need, because we were out in the field, and you might have a mobile unit, but you may have a little truck, but you cannot access all the distant and areas. So because of the geographic and the roads, so it's not possible. So what we did, we came up with an idea to be able to reach those people living in those areas. So that's why we came up with this backpack strategy. We found the vendors, and this is being implemented because we are evaluating this intervention because there are very many pros and some cons. So we need to identify those and see what we can do. Thank you, doctor. In Latin America, doctor, in Peru has the highest incidence of MDR-TB in Latin America. What are you doing about this? Yeah, it's a very hard question. Yeah, Rafael is going to come next month, by the end of the month here, because we know this is a serious situation for us, because it's not only local, but there are many cases that are being exported of MDR-TB for the different countries in the region, to Chile, Argentina, Bolivia, and so on. So you're Peruvian? Oh, okay, most likely you have MDR until proven otherwise. So it's a law that says that we're protecting the budget allocated to TB. However, we need much more than we're getting, and we need to do a lot more than what we're doing. So there are some serial situations. The situation is very complex because we don't know if this president is going to be in office for a month or a couple months. There is a lot of political instability, in addition to the pandemic that has been impacting our healthcare system. So we're in a tough spot right now. What we have is that we have the prescription of the receipt, but we know what we need to do, but for that we need a lot of resources, time and money. So we want to use experts throughout the countries. We're going to complement it with some other tests. We need to expand digital X-rays throughout the country and be able to have CAD for the analysis of those X-rays. So we know what we need to do, but we don't have the resources. We need to update the strategic plan and try to find source of financing for us and some more allies in the community, the civil society, the academia, people from the academia that wants to join us and work together so we can improve the situation. It's not easy. We know that it's going to take up a lot of time. It's going to take a lot of effort, but we need to do it now. Okay, doctor, thank you so much. So in addition to the programs at TB Mobile and the backpack program, who is financing these efforts? We started in 2019. There have been different sources of financing. We have gotten resources for HIV. We have gotten resources from the Global Fund through different projects going on in different countries. We have been able to work with the Ministry of Health. They are those who allocate these resources, and we have been able to sustain this TB mobile initiative, especially in the mountain ranges and places that are hard to reach. But we need to find in the next. We have to make sure that all these initiatives can be regular, set up in a regular schedule, so that we can be more effective. But the new part is we're getting international support, but the idea is that of course we still depend greatly on the federal funds. So in addition to this, regarding these programs, what are the challenges that you have been facing for these programs? Well, I mentioned something that first we need to have the strategic ally is the health department, of course, the Ministry of Health, because they give the authorization, give the green light for these projects. So that was a hard start for us. It's difficult, because we need to find evidence of how those programs would operate and evidence that how beneficial would be for us. Then we have to fight against the stigma. It's been a big challenge for us. That's why the initiative, we don't do TB fairs, we do health fairs, because in that case, we can just hide there and give camouflage among all different tests. Because we know that people don't show up to those fairs because of the stigma. They don't want people to know that they do have TB. And another thing is we need to, a major issue is that especially the fact that sometimes we don't want to treat people that only have traces on the expert. So because the healthcare system was only using vesselloscopy, they were not familiar with these new techniques. That was a problem. So we need to train them, educate them, and to let them know how they could diagnose and how they can treat people, even if they don't have, by following different diagnosis methods, and maybe use community leaders in these outreach efforts to, working for people working at shelters. They are great because we should let them know that they are part of this effort, crucial part of this effort, and they will help us improve the situation in the community. So, yes, I really suggest you read these guidelines by the WHO. Thank you, Doctor, for your participation and such an interesting presentation. We want to thank our sponsors, Magno and Nissan. We also want to thank the interpreter, Claudia Valencia, who interpreted the conference from Spanish into English. The English presentation, you can find it in the FoVI-TB YouTube channel. And we also want to thank the support from the YouTube, Facebook, and Imagen FoVI-TB, and CEPA from the UBC Mexicali. All of you, we want to invite you next week. Want you to come with us next week for the third session of this virtual International Forum on TB at 9 a.m. Pacific time. We're going to have Dr. Javier Sanchez, Dr. Socio Chiapas with the conference TB on indigenous groups in Mexico, Dr. Isaias Orozco, the chief of the diagnosis and treatment for TB, who will be talking about comprehensive management and multidisciplinary approach for TB. I'm gonna send you some information on your email. I'm gonna show you the link for the first session. And later in the day, we're gonna send you the link for the second session if you want to check it out. Thank you so much. Thank you.